names of the patients whose lives we save can never be known. Our contribution will be what did not happen to them. We are building a fire for someone else to be warmed. We are digging a well for someone else to drink. It's great work. It's very rewarding work. It's work that needs to be done.
We're so pleased that you've decided to join us for this session of KHC Convenes. You happen to be here for the very first one, and we're thrilled that you are interested in learning a little bit more about how the pandemic has actually impacted performance improvement and quality and patient safety in the healthcare system. KHC has been in the education business since our very inception. We feel it's essential to equip providers just like you who are doing the work of healthcare every day with the information that you need, with the technical knowledge that will be helpful for you, as well as provide you the opportunity to be exposed to some of the broader concepts and ideas that are emerging around this area in which we work. We are excited to have with us today Tom Evans. Dr. Evans is a family physician, but for the last number of years, 14, maybe 15, he has run the Iowa Healthcare Collaborative, and KHC and IHC have been longtime partners on a variety of initiatives, and we're thrilled that he's here today to briefly discuss the kind of innovation that can come out of a disruptive season like the one that you all have endured. So we look forward to these projects. We look forward to learning from you how whether they were beneficial or not, and we hope that this becomes really an opportunity for us to convene broader conversations in addition to having the other educational experiences that you have come to expect from KHC. So thanks again for joining us, and I hope you enjoy Dr. Evans.
Hi, my name is Tom Evans. I'm a family doc, and I'm going to be presenting today on a topic called innovation out of disruption. I think we all know that we've been through kind of some crazy maker times over the last year, and it's impacted the way we as providers address the whole topic of performance improvement. I think we would all agree that we're leading into a period of healthcare reform. But I think it's important for us to recognize that the pandemic had some very dramatic effects on that whole process of performance improvement. And I think it's been a crazy maker. It's certainly slowed some things down, but interestingly, it's actually catalyzed some other things, and it's making it easier for us to move forward on some things that we've needed to move forward with. So with that, I'm really looking forward to talking with you today about that. First slide, please. The objectives today that I want to cover are, first of all, let's kind of talk about the state of healthcare reform. We all know what we've been through for the last 10 years. Let's talk a bit about that. And then I'd like to introduce the topic of stakeholders. We spent a lot of time thinking about, we know there are other folks in healthcare that need to be involved in our discussion, but I don't know that we really think very carefully about how we need to be involved with them. So we'll spend some time on that. And then finally, I want to close with an exercise that we're doing in my organization, the Iowa Healthcare Collaborative, specifically looking at what happened with the pandemic and how can we now, what innovations can we use to kind of move forward together. Next slide, please. I have used this slide for several years and I love it. I think everybody recognizes we're in this period of delivery system reform. And there's an old joke that in a period of delivery system reform, who has to do the reforming? Well, the delivery system, and that would be us, primarily the audience on this call, hospitals, physicians, ancillary providers, but we who deliver the care, the pressure has been on us to try to create strategies to deliver care differently. And I like this cartoon because it reminds me that we're on a volume-based treadmill. We're paid in a fee-for-service system running as fast as we possibly can, chasing some ethereal goal called value. And how much value is enough? Well, just a little bit more, and we're running as fast as we can. It's been a crazy maker for the last 20 years. But over the last 10 years, there have been policy changes and CMS has introduced changes that in an effort to change us from a volume-based to a value-based reimbursement system. And maybe it's not completely change us, but at least to recognize different ways of practicing. There are three levers that the federal government has used and everyone is using to kind of get us to change how we do things. They're paying us differently. They're putting different payment incentives in place. So we all know we're moving to this capitation model, value-based reimbursement type model. There's less fee for service and more value-based reimbursement. We know that the federal government is talking about distributing information differently. There's health grades, there's the CMS stuff where they've got data that they're pulling together where consumers can actually look at that. And they're working to engage consumers as activated partners in their care. Those two things are important, but it's important to realize that the whole crux of the matter is, can we deliver care differently? They're using payment and information distribution to try to help us advance toward care delivery and changing the way we deliver care. That's been our journey for the last decade, and it's been a crazy maker. Next slide, please. I want to introduce another metaphor to you here about, and it really is the impact of the pandemic. You know, when we look at these three levers of payment and care delivery redesign and distributing information, there are all kinds of different processes in that, and some of them moving quickly, some of them moving slowly, but I think we would all recognize that we've been slowly moving toward value-based reimbursement. Anybody, any stakeholder involved in that, I think everybody was going in the same direction, whether you're a payer or an employer or a provider. It was moving kind of at a glacial pace, but we were generally accepting that we were moving toward value-based reimbursement. And it's been kind of an evolutionary rather than a revolutionary process. The pandemic changed that. If you would imagine these lines like light rays and all of the different wavelengths are all aligned in one direction, you get white light. What happened with the pandemic was it introduced a prism. Next slide, please. And what that did is it separated these different topics. And what's interesting is all these different topics got changed. Some of them all of a sudden are moving much faster. Some of them have stopped dead in the water. Some of them are moving kind of at a moderate pace, but there's a new energy for change today. And I think what's interesting here is that the strategy of the black arrows really needs to change. We now have to recognize and take advantage of the energy from these other topics as we move forward. We'll talk more about that in a moment. But what it really introduces is the whole concept of strategy. And we need a different strategy as we go forward. The world is going to be a different place after the pandemic. Next slide. So let's talk about strategy. What is strategy? And, you know, we use that, we throw that term around a lot. Oh yeah, it's a plan, or it's a kind of like where we're going, or whatever. This is a formal definition of strategy. That strategy is about sustaining a competitive advantage. I think everybody here wants to have a successful business. They want to have a successful practice. So it's about creating a competitive advantage so that you can be successful. But the way we create that competitive advantage is through creation of value. So the why is to create a competitive advantage. The what is we create value. The who is who do we create value for? Well, for our customers, obviously, but there are others that we create value for. Other partners who care if we're successful or not. So, and we call, we call those individuals stakeholders. I think it's important to recognize that as we pursue this new strategy, it's not just about healthcare. Our stakeholders are also going to have to win in that discussion. And I just want to talk about stakeholders for a moment. Why do we care about stakeholders? Next slide. Well, let's talk about what a stakeholder is. A stakeholder, we kind of go, yeah, they kind of care about if we win or not. Well, stakeholders, what is a stakeholder? They're basically some entity, an individual, a group, or an organization that is either is affected by us or they are attempting to affect us. So they are influenced either positively or negatively by us and by our plan and ergo our decisions and the actions of our organization. So stakeholders are important, and they've never been more important, especially as we pursue value-based reimbursement. Next slide. Who are healthcare stakeholders? Well, obviously, when we deliver care, we think about our patients. So, but it goes farther in that care delivery line here. In care delivery, we want to be effective with our patients, but also in certain situations, we may have clients or those who send us patients. So those are important stakeholders. The payers. What are the payers? The payers are basically, they're not just the guys who create, they're not just the guys who don't pay us for what we do. They are the stewards of the resources, and they are responsible for making sure that what gets paid out is paid out for the right reasons, Bottom line is they're stakeholders. They want to make sure that they have effective services provided for what they're paying out. Next category, those who define the context with which we do our work. So legislators and regulators and accreditors, those who influence policy. How about our communities? There isn't one hospital here or physician here who really doesn't think very highly of the place where they are working. We are working to create economic engines locally, and we've got to make sure that our community needs are being met. And then finally, collaborators. There are others that are on my team that we work with in certain ways, maybe intimately, maybe not very intimately, but basically we work together as a team to try to move the ball down the field. Those are all different healthcare stakeholders. Next slide. Why do we care? Why do we really care about the stakeholders? Primarily because they have control over our success. Usually stakeholders have some control over resources that we need. It could be physical resources. It could be workforce locally. It could be access to capital or financial attributes of your relationship. And then everybody knows about information. Someone may have information that I need to be effective. Stakeholders all in some way bring some unique component to our team to be able to move our process forward. The important thing here is as we develop new strategies, the actions of stakeholders can make us successful or put our strategy at risk. So when we do our new strategy, we've got to take our stakeholders into consideration. Next slide. I think it's important to realize that it's not just healthcare on this treadmill anymore. As we move toward value-based reimbursement, it's important for us to realize that in healthcare, what do? We fix broken people. In a fee-for-service system, we fix broken people. When someone comes to us with a problem, we will correct the situation. We bring them back to this thing called health. They're moving us to a different reimbursement system called value-based reimbursement, where our job is not only to fix people when they're broken, but to try to keep them from getting broken. And to do that, we need all of the stakeholders involved. This slide, I love it because healthcare is on the treadmill pursuing value-based reimbursement, but many other components, long-term care, pharmacy, public health, our communities, the local employers, everybody that we're working with, it's important for us to align those stakeholders. Next slide, please. So it brings us back to the question of strategy. If the purpose of strategy is to sustain a competitive advantage through value creation for our customers and our stakeholders, we need to be thinking about something. Like when you're constructing strategy, it's not just, it's actually a three-legged stool. There are three pieces that you need when you construct strategy. Now, everybody knows that our organizations have mission statements, vision statements. Even if you're just an individual physician, you kind of know why you're practicing, what you want to do, and why you're there. So those are called directional statements. That's the first leg. Your directional statements are basically your declaration of what you want to do, why you exist. So mission, vision, values, cornerstones, goals, if you will, those all tend to be your directional statements. So we start that. The second leg of your stool of strategy is basically an internal assessment. Well, if that's what we'd like to do, what can we do? So you look at your internal capacity and what do you have for staff and how many physicians do you have and what services does my hospital provide? And you kind of look at what we can do. Now, often we kind of stop there. We kind of say, okay, this is why we exist and this is what we can do. Now let's plant ourselves in the market and see what happens. Okay, but you're only 2 of the 3 legs on this stool. The third leg is basically an assessment of what should be done. What does our community need? And it's looking out there and seeing what is needed. So directional statements, internal assessment, and an external assessment of stakeholders. At IHC this year, we're going through a pretty rigorous strategic planning exercise. And one of the things we're doing is a pretty rigorous external assessment of our stakeholders. And I thought just kind of walking through what we're doing might be instructive, kind of as you think about how you might go forward as well. So next slide, please. In our, and this slide basically underscores that when you're building strategy, you have your internal environment, you have the vision and goals, and again, external environment. And just to reiterate, what should we do? What do we want to do? What can we do? That mushes together into an integrated circle, if you will, that kind of becomes clear. This is where we need to be. And now you need to construct a strategy to get there. So next slide. This is our IHC strategic analysis. And what we've done, we've sent out over 80 what I call stakeholder profiles. And we asked a couple of simple, kind of 4 basic categories of questions. Number 1, tell us about yourself. What's your mission, your vision, your values, and your goals? That's that acronym there. And basically, what do you aspire to do, but what are you able to do? That's that directional statements and internal assessment. The second piece we wanted to know is, do you really want to work with us? And how do you want to work with us? So it's basically a description of your commitment to collaboration, but also what are the unique things that you bring? Just because, like with a payer, for example, when we go to our payer, we know that they influence rates, but they also influence policy and they have data. So what things can we use together to build that new thing? So once we kind of understand who they are and how we can work together, now we wanted to find out where can we go together. So basically we asked them to describe the challenges to their vision. If they have their own mission, vision, values, and goals, what are their barriers? What are the things that are keeping them from achieving what they want to achieve? And then finally, what are the impact the pandemic do to us? And this section has been fascinating because we've had some people describe terrible barriers and some people describe breathtaking innovations. So what was the impact of the pandemic? How is your world different? Now, this is what we've asked folks. The next question might be, so who did you ask? Did you only ask your friends? No, we asked anybody that had, remember that stakeholders can be collaborators, but they can also be competitors. So because the competitor is going to have a stake on whether you're successful or not. So we asked everybody we could think of, basically. Next slide here. Who's involved in that? We have patients. We have a cadre of patients that we've asked their opinions. Providers. This was a very broad category. Specifically, we're breaking that information into hospitals, hospital input, physician input, ancillary providers, pharmacy, long-term care, others. And then we've got a new category we added this year was the health systems, the integrated systems of hospitals, physicians, and ancillary providers who are accepting risks together. We think their perspective is very important to have. We asked payers. We asked government. Now, what does government mean? Well, it means specifically we're gathering the input from CMS, from our local Medicaid, from state government, and from other. And then we gathered information from others such as QIOs and quality improvement consultants, and frankly, associations of hospitals, medical society. Those are very important to us, but pharmacy association, some other folks. Let's just gather and get as much information as we can about what the stakeholders need as we move forward. Next slide. We have identified kind of 5 big rocks that keep coming out. How is the world different? What are the new challenges that need to be addressed? And these 5 big rocks are, each one is a lecture onto themselves, but let me just spend some time discussing them. The first one, it says telehealth and new models of delivery. I probably should have put that as new models of delivery, parentheses, telehealth. The pandemic forced us, and I think everybody knows this, we couldn't see our patients. We have, in the fee-for-service world, we have a payment system that's based on someone sitting in our office for us to generate a charge, and we no longer could do that with the pandemic. So we had to find alternative methodologies, and one alternative methodology has been telehealth. Telehealth is not the answer to all of our ills. It is, however, a new innovation that allows us to do all kinds of things. And again, this is about new models of delivery, not just telehealth, but I think there's been a recognition that we don't have to just have people sitting in the office to generate good care. So we're exploring, I think healthcare is exploring new ways of delivering services. This is a genie that's not going to go back in the bottle. The second big aha moment has been basically, we have got to have better data than we have had. We need advanced analytics, and we need to have the data talk to each other, data interoperability. We need to have a large amount of data. We need to have the data talk to each other. And then it's one thing to have data. It's another thing to use the data to do stuff. I feel like in the last 15 years, we spent a lot of time trying to just pull together data sets, and we're really not very far along on intelligently using that data to provide information that directs better care. So that's a new need, and frankly, we advanced that some because of the pandemic. Number 3, the whole construct of workforce and managing presence. That really is saying 2 things. Do we have a workforce? Can we get enough employees to do what they need to do? And where they do what they need to do is changing. The whole construct of, are we remote or are we on site? Does everybody have to be here, or can we provide services remotely? Can we use a hybrid model? And what does it mean to provide a hybrid model? How do you provide a hybrid model? What happens to my culture when we use a hybrid model versus an on-site model? All new questions, but again, another genie that's not going to go back into the bottle. Finally, 2 topics that have been old standing that got new energy. The whole topic of behavioral health. I think everybody knows that we've been underinvesting in mental health for decades, and all of a sudden it brought that to a crisis boiling point. So we have all new calls for how we address behavioral health. And then last but not least of the big rocks, the whole topic of reimbursement. What was interesting is that in our healthcare system, where we are primarily fee-for-service and dependent upon fee-for-service, when we couldn't get people into the office, it certainly underscored how important it was that we have a different reimbursement model that allows us to provide care whether someone is in the office or not. So these are kind of the big rocks that we've seen come out of this. And fascinatingly, we've seen people create innovations that began to address these different components. Next slide, please. So some of these innovations out of disruption, well, we've seen a new spirit of willingness to work together. People describe healthcare as being siloed. And with the pandemic, we moved from silos to barn raisings. We saw people coming together and trying to innovate and find new ways of doing things in different ways to get the work done. So we're seeing a new willingness of participation, hospital to physician, physician to physician, specialty to specialty, specialty to ancillary. We've seen hospitals and physicians working together. We've seen pharmacists and physicians working together in different ways. We've seen hospitals and long-term care trying to figure out, how do we manage these difficult situations better? So there's a new spirit of willingness to work together, and it's going to be necessary. we're going to have to engage our stakeholders in a meaningful relationship strategically to be able to move forward. Another innovation that I've seen is kind of like, it's kind of a duh moment, but it's the mastery of new skills. And these acronyms here are in performance improvement, in patient safety, and in information technology. You know, what's the old adage about necessity is the mother of invention? But because of the pandemic, we couldn't do what we'd always done. Now, we've had many IT skills around. For example, this Zoom thing. Zoom's been around for a while. All of a sudden, it was the only way we could do things. And what happened for us to be able to do it effectively is everybody had to learn how to do Zoom. And I've had to, I'm just thinking for myself, I've had to master different aspects of running things, computer stuff. We've done the same thing with patient safety. We had to have new infection management protocols as we did things. And performance improvement, we had to begin to track different populations and manage different things. So there's been we took a moment because of the pandemic to begin to actually master many of the skills that were available to us. And as we master them, we get better and it creates new opportunities. Another innovation we've seen is, for years, in my opinion, public health and healthcare have kind of been two sides of the same coin, but never acknowledging the other. What's happened is, in a public health crisis like the COVID pandemic, it made us realize that in the construct, one side fixes broken people, the other side is about keeping them from getting broken. But in value-based reimbursement, it brings those two pieces together, and we have to work together. So we're seeing more and more effort to integrate public health, community solutions into what we're doing on healthcare redesign. Commitment to include the patient. We have talked for years about patient engagement. Telehealth and some of the things that have happened with the focus on the patient through the pandemic have created a whole new dialogue. And I don't think patients are going to go back. We have, as we build our strategies, they're a very important stakeholder, sometimes impatient, but they're a very important stakeholder to our new strategies. So building customer-focused product is going to be very important going forward. Finally, on reimbursement, this is the innovation is, this is a good news and a bad news story. There are pluses where we have a complete new appreciation for value-based reimbursement. We now recognize that if we would have been paid in a value-based reimbursement model when the pandemic hit, we wouldn't have taken a significant contraction in our revenues. By the same token, the minus of the situation is the progress we were making toward moving toward value-based reimbursement stopped dead in the water with the pandemic. And I've had several health systems tell me that we really don't see ourselves moving forward too much with value-based reimbursement for now. We were so shocked with the fee-for-service system that everybody's just kind of stopping. So I think it's important for us to recognize that this reimbursement topic isn't going to go away, and we need to continue to embrace how we move towards some kind of a value-based reimbursement world, because it gives us stability for the next situation. So with that, let me close with just kind of some big thoughts and encourage you through the Kansas Healthcare Collaborative. You guys have some real great resources, and you should be taking them and working forward. So what are the bottom lines here? Number one, the disruption that's caused by the pandemic is catalyzing a whole new environment of innovation. We're asking questions we wouldn't ask before. We're actually kind of kicking around, maybe doing some things we never would have done before, because it's a catalytic experience. Number two, new strategies need to focus on the creation of value. It isn't just how much stuff can you sell somebody else, how many office visits can I generate, how many procedures can I do, but you need to begin to ask the question, for my customers, for my stakeholders, how do I create win-win solutions? How do we make sure that everybody's treadmill works going forward? We need to create value. We need to engage our stakeholders. Number three, the stakeholders will impact our success. So in a value-based world, how effectively we engage our stakeholders and build community-based strategies will dramatically affect our success going forward. And the last thing is just my commercial for KHC. KHC, the Kansas Healthcare Collaborative, has been a sister organization to the Iowa Healthcare Collaborative. We've worked together very closely for over 10 years, and I'm proud to call them a sister organization. But KHC is a unique provider-led performance improvement resource. KHC, with its kind of parentage through KHA and KMS, this is a provider-focused organization. And again, back to that thing of, in a period of healthcare reform, who has to do the reforming? The provider community is key to creating the changes in care delivery that will be sustainable. The world isn't just about healthcare transformation. For us, it's about sustainable healthcare transformation. And you've got a great resource in Kansas with the Kansas Healthcare Collaborative. So thanks for listening today. My very best on your performance improvement journey. Godspeed into a new world. Thanks.